Welcome back. This is Dr. Jin Sung, where clinical excellence meets excellent results. Today, I'm excited to introduce our three-part series on gastrointestinal disorders. So when patients come in to the office, we ask what their symptoms are, what is bothering them. But what people don't realize is that the gut or the gut microbiome may affect other areas that people are not used to thinking about, like the skin or autoimmune disease or psychiatric disorders. So I'd like to show you this board behind me, and let's kind of go through that in terms of what the GI symptoms might be, what immune responses might be, and then some other non-GI related symptoms that can occur due to the gut microbiome, okay? So when we look at this board, typically when patients come in, they have GI symptoms, right? Because it's gastrointestinal disorders. So they'll complain about bloating, distension. So what would cause bloating and distension in the GI tract? Sometimes it can be just food, right? Sometimes it can be something called SIBO, or small intestinal bowel overgrowth, right? And then we have constipation or diarrhea. That can also be related to food, and it can also be related to SIBO. So basically, it could be related to those types of things. If we have abdominal pain, cramping, it could be food related, it could be stress related, it could be a parasite, right? And up here also it could be a parasite. So there are a variety of different causes for distension and bloating. The most common things that I see is that people have food sensitivities that they are unaware of. So it's important to understand what types of foods typically cause bloating, distension, loose stool, and so forth. And the five most common categories are gluten, dairy, soy, lectins, and nightshades. Those are the five main categories. There are others, but those are the ones we try to focus on if the only intervention we can do for them is dietary, right? So we look at these types of issues. What other people don't realize, or patients don't realize, is that there are immune issues related to the GI tract. So when we have food sensitivities, it creates problems in terms of the immune response. So let's say you have gluten, I get bloated, I feel like I'm swollen, I get brain fog. That is an actual immune response to a protein in gluten called gliadin. There are other types of proteins within that gluten molecule, but the most common one is gliadin, okay? So when we have food sensitivities, we can actually have an immune response. Another one is chronic inflammation. So if someone has, let's say, an autoimmune disease like Hashimoto's thyroiditis, and they have generalized inflammation in their body, right? They become more susceptible to food sensitivities and creates more inflammation. The inflammatory process can wreak havoc in our system in terms of the brain function, skin, and so forth. Another one is chronic pain. You know, we have people who have fibromyalgia. Right? They have pain everywhere. They have chronic pain and they don't understand why. And it could be related due to, one, they can be obese and they have generalized inflammation because they're obese. Second, they're sedentary and they're not moving very much, so they get no stimulus. Third, it could be food. Or another one could be that they had some sort of trauma prior and they've never fully recovered from that trauma, whether it be physical, emotional, or chemical. So there could be underlying mechanisms that create pain and then the inflammatory process, and they become more sensitive to certain things like allergens or food and so forth, right? Another one is skin. Skin issue is very prominent with food allergies. So when a child has eczema, one of the first things I tell them is, hey, don't eat any dairy. Don't give the child any dairy. No milk, no yogurts, no cheese, right? And a good majority of them will start to improve with dietary changes alone. So skin reaction can be related to GI dysfunction, could be related to food sensitivities. Another one is autoimmune disease. Obviously, there are things like Crohn's disease, celiac disease. These are all common types of inflammatory processes that can occur, which are autoimmune in nature. And that in itself will create generalized issues, but also GI issues, right? So when we look at a typical patient who comes in with GI complaints, we also ask about these types of things. Do they have an autoimmune disease? Is their skin clear? Do they have chronic pain? Do they have chronic inflammation? When we check for inflammation, we can check something called ESR or CRP, right? And then that can help us decide if they have global inflammation, right? There's other markers you can also check, like ferritin, which can be inflammatory in nature. Homocysteine can be inflammatory also. But these are the immune issues that we look at. Moving over to this side, non-GI related symptoms. Who knew, food issues, GI issues can also manifest as depression and neurodegeneration, right? Poor metabolism, obesity can also can occur due to GI issues, malabsorption, right? Poor absorption, diabetes. As a matter of fact, all these, there are certain gut microbiome or microbiota that are related to these types of conditions. If you look at the research studies, there are certain bacteria or dysregulation in certain bacteria that can create these types of problems. Does it mean that you have to give them the bacteria? Not necessarily. It might be just giving that patient the proper fibers so the gut microbiome can grow and develop into a mature state where it can be self-sufficient, okay? So when we look at GI or gastrointestinal disorders, you have to look at GI symptoms, but we also have to look at immune issues, and then you have to look at, do they have also other issues that are non-related to GI symptoms or immune symptoms, right? So let me give you an example. When we have a patient who comes in and they have complaints. So a patient might come in and they say, hey, Dr. Sung, these are my complaints. I have bloating, constipation, increased food reactions. I can't eat anything. I eat something, I feel like I'm bloated, right? And then they also have depression. The patient might be coming in thinking that this is the only thing they have, or that's the only symptom that really matters to their condition, but depression also matters, right? So when we look at a full case history, we say, all these things can be related to GI. And then we go over here, and this is our clinical thought process. Do we say, does this patient actually have neurodegeneration? Things like Parkinson's, Alzheimer's, dementia, right? Because people don't realize one of the first signs of neurodegeneration is smell, right? Poor sense of smell and taste. Smell and taste is one of the first signs for digestion, right? When you smell good food, right? You start to salivate, right? These cranial nerves start to take in that information and start to increase enzymes in your stomach and bile and digestive enzymes. So early neurodegeneration is a differential when we have a patient who comes in with these complaints. Do they have early degeneration? Do they just have a bad diet? The standard American diet or SAD diet, right, is consistent of high carbohydrates, sugars, refined foods, artificial flavors, right? High amounts of gluten and dairy. So do they have a bad diet that can lead to what they call dysbiosis or quote unquote leaky gut, intestinal permeability, whatever you want to name it, right? Do they have that? This one's easy. If you have a bad diet, let's correct that one first and see what happens, right? Early neurodegeneration is more difficult to pick up. It takes an in-depth consultation and some questions that really delve into how that patient's brain is functioning, right? Or a neurological exam will start to help determine that. Things like smell, like I said. Do they have poor saliva production. They take forever to eat. That can be problematic. Another one is celiac disease. And you say, hey, do we have celiac disease? Do we have an autoimmune process related to gluten, right? If you have celiac disease, none of this is going to go away until you figure out that, hey, it might be gluten that might be the problem for you, right? And then you have parasite infections. Parasite infections are more common than you think. Things like H. pylori, right? It's common. It's very prevalent here in the United States. H. pylori will start to decrease stomach acid, right? But you need stomach acid as a signal agent for bile production. So you need every step from the top down, right? The thought of food, smell of food, taste of food, hitting the stomach, acid production, bile production, pancreatic enzyme production. You need all of that to go and fix the underlying mechanisms. The other one is leaky gut or intestinal permeability we talked about. Specific food reactions. Sometimes we don't know. It might not be gluten, dairy, soy, lectins, and nightshades. It could be something else, right? It can be a food coloring that you can be reacting to. So it's important to understand what type of food reaction you might have, right? So we can put patients on elimination diets where we eliminate the top 5 foods or food categories that create inflammation and see how a patient does. Or you can do advanced testing. I use a lab called Cyrex Labs, and they do both cooked and uncooked foods to determine whether you have a reaction to that. How great is that, right? If you have broccoli and you could eat broccoli raw, but you have a reaction to cooked, or vice versa, right? You react to uncooked broccoli, but once you cook it, you don't react to it. You can do an immunological test, which will check for IgG and IgA. So it's an important test if we have, or we get stuck with patients where we go, we eliminate those foods, but why does this patient still react to certain things, right? So we can do specific food reaction testing. Gallbladder problems. Now, gallbladder problems is very underrated and underlooked at by even functional medicine practitioners. Gallbladder function is huge, right? If you have a slow gallbladder, a sludge, you have gallstones. If you have Hashimoto's thyroiditis, oftentimes I have patients who come with thyroid issues and they've had their gallbladder removed. It wasn't a gallbladder problem, it was a thyroid problem. The thyroid was not functioning or signaling properly to the cells of the body. And then the gallbladder becomes very sluggish and they get pain on the right side, right? And they get their gallbladder removed rather than saying, oh, wait a minute, you have Hashimoto's thyroiditis. Let's see if we can manage the autoimmune process of Hashimoto's thyroiditis before we remove the gallbladder. It's a very common surgery that occurs with a lot of thyroid patients. Another one is demyelination of the enteric nervous system. Big words, right? Basically, your gut is your second brain and it starts to degenerate, especially after things like concussion, right? And you develop POTS, or you have neurodegeneration, which also can degenerate in the gut, right? Your second brain, your gut, the enteric nervous system will start to degenerate. These are patients that are very difficult to help because they're degenerative in nature, right? It doesn't matter how many supplements you give them, the neurodegeneration or demyelination of the enteric nervous system may not return to its optimal. Sometimes you have to do neurological exercises, brain-based exercises that can stimulate the enteric nervous system. A good one is like humming, gargling, gagging, which stimulates the vagal nervous system, but in turn will start to help stimulate the enteric nervous system. Sure, nutrients and eliminating those foods that are inflammatory can be helpful, but these cases where you have true demyelination of the enteric nervous system, it becomes very problematic in terms of helping those patients. The other one is small intestinal bacterial overgrowth, or SIBO. Now, SIBO comes in multiple flavors, right? You can have diarrhea, you can have constipation. You can bloat by drinking water. You can bloat after every meal. By the time 5 o'clock or 6 o'clock rolls around, Your belly is out to here. You're 4 or 5 months pregnant. SIBO is the #1 cause for IBS, irritable bowel syndrome. Right? People don't realize that. There are simple tests that you can do for SIBO. Right? You can do a breath test where they can check for hydrogen and methane gases, and that will help determine if you have SIBO. Right? So if you have methane gas that's highly elevated, you have constipation typically. Or if you have hydrogen gas that's highly elevated, you have diarrhea. Or you can have a mixed bag, alternating. Diarrhea, constipation, right? And SIBO develops a lot in patients who have concussions because the brain is damaged to the point where the cranial nerves in the midbrain do not function as well and will start to affect the GI tract, in particular the vagal nervous system. So SIBO is a very difficult case for some. It could be very easy to help, or sometimes very difficult to help because of the underlying mechanism of brain trauma. So post-concussion patients will develop something called POTS, right? And POTS starts to affect the variability of your heart rate, blood pressure, right? You get dizzy, lightheaded. And those patients often develop SIBO and bloating and issue or digestive problems in general, okay? So these are the symptomatology. It's a lot more complex. You have to look at the differential diagnoses that we want to see with a patient and say, what's going on? How do we figure out this patient when they come in with these 4 complaints? Then we start to look at all of these if we're thinking they have a problem with the gastrointestinal tract. Today we're going to go to part 2 of gastrointestinal disorders. In the board behind me, we're going to explain some of the clinical signs and symptoms of GI issues. Last week we talked about all these different mechanisms that might cause what appears to cause symptoms outside of the GI tract. So if we have some problems, let's say of eczema, right, which is a skin issue, it may actually be related to GI issues or food sensitivities. So in the clinical practice, when a patient comes in, we have to ask certain questions. What is going on with this patient? Is it a true GI symptom, or is it other factors that create problems for this patient? So when we look at it in terms of clinical signs and symptoms, it's not just about stomach pain when we talk about gastrointestinal disorders. When we look at it, we have to do, 1, does the patient have a healthy diet and lifestyle? Do they actually live a clean, stress-free life with proper foods that are organic and avoiding foods that create inflammation? Foods like gluten and dairy are big factors in GI issues. So when we look at a patient, one of the first things we like to do, which is our foundational piece, is to say, do they have a healthy diet and lifestyle? If not, we have to go ahead and modify those, right? Refined sugars, gluten and dairy, sometimes soy can be problems. In some patients, it can be lectins, like nuts and seeds can be problems for those patients. So alcohol use can also create a breakdown of the gut barrier and creates depletion of B vitamins. So you have to look at lifestyle factors, right? So it's very important to look at that as a foundational piece. So when someone comes in, they are eating a lot of sugar and their stress is out of control, they're drinking alcohol, and their food is basically pizza, burgers, and whatever else they can grab on the go. Then those are easily modifiable if the patient is willing to change, right? When it becomes more complicated is when we go a little bit deeper into what's going on with the patient. So does a patient have autoimmunity? Do they have immune response to their own self-tissue, right? Some patients have hypothyroid, or the #1 cause for hypothyroid might be Hashimoto's thyroiditis. So if you have inflammatory processes where your body is creating an immune response to its own tissue, in cases of GI issues, it can be Crohn's disease, it can be celiac disease. But there are other autoimmune diseases that can be affected, like rheumatoid arthritis, where it affects the joints, or psoriasis or skin, right? So we have to ask those questions. Is it affecting our intestinal barriers? Is it affecting our brain, our enteric nervous system, and breaking down that nervous system? So we have to look at it in terms of, does a patient have autoimmune issues? Next is neurological. Do we have decreased output of the nervous system, right? More commonly what we call the vagus nervous system, cranial nerve 10. When we look at this, cranial nerve 10 goes down into the GI tract and innervates a lot of the organs, right? And your large intestine, small intestine, etc. So if your vagal function is not at optimal, then you may develop constipation. You may develop slow metabolism or absorption in the GI tract. So we have to look at vagus output. And then something called dysautonomia, or sometimes POTS. It can create issues with your sympathetic system, where parasympathetic and sympathetic systems are unbalanced, right? Usually there's high levels of sympathetic drive with these patients, right? If you're under a lot of stress or scared, right, or in a crisis mode, you're not really thinking about eating, right? Because the digestion will not be there. So your balance of your autonomic system is very important. Also neurodegeneration, just people who have maybe Parkinson's early on or Alzheimer's early on. This is neurodegenerative, and patients don't realize that the brain output is affecting GI function, okay? Next thing we ask about is metabolic conditions. Things like diabetes. Does the patient have issues with diabetes? Are there type 1, type 1.1, 1.5, or type 2 diabetic? So we look at, does diabetes drive some of these issues? Sometimes obesity will drive that, because the adipose tissue will create different hormones or imbalance of hormones. Hypothyroid, okay? If you don't have enough proper levels of thyroid hormone, then everything can slow down. GI function, gallbladder function, all these things can be affected. Another one is pathogens. Pathogens or infections of the GI tract. One of the most common infections in the world or in the United States for GI is H. pylori, or Helicobacter pylori. This is a very common infection which decreases stomach acid, which can create malabsorption in the stomach, or breaking down of the proper foods, right? If you can't break down your proteins and your fats and your carbohydrates, then it will not be absorbed properly. So we're looking at pathogens like H. pylori. There are other pathogens like worms and overgrowth of yeast and fungus and so forth. So pathogenic tests would be important. So when we look at it, we have to ask the clinical questions. Also, their medications also create problems. So if certain medications create malabsorption issues, then you're not getting the nutrients, right? Or some medications might affect gut lining and starts to kind of break down the gut lining and creates quote unquote leaky gut, right? So it can create a lot of different problems. So in the clinical practice, so when a patient comes in, right, I think a lot of practitioners miss this component, is that when a person comes in, they go, oh, I have stomach pain, or I have eczema, right? They don't do the necessary workup. They don't look at the patient as a whole individual. So first we've got to look at chief complaint, right? We take our time looking at what is the history? What led this person to come into our office? What is the long history of things? Was there a lot of antibiotic use that decimated the gut lining? Are they on antacids for years and years and years? Are they drinking a lot of alcohol, right? Was there trauma, like a head trauma or concussion, right? These are all important factors in terms of understanding why a patient might have GI issues. So the chief complaint is very important. Obviously, dietary history. What is their diet like, right? Do they eat at appropriate times? Do they eat the right types of foods? Are they just eating a lot of sugar or maybe just eating a lot of gluten, and they might not realize they have gluten sensitivity, or they might even have celiac disease, right? And then we also use clinical forms, right? Rather than spend, 2 hours asking these questions, we have extensive forms in our office where we ask the patient to fill those out at home. And it'll take maybe 30 to 45 minutes to an hour for some patients to fill those forms out, because we have to ask all the necessary questions and leave no stone unturned, right? So we have to kind of figure out what is going on with this patient. And then when we get the clinical history, when we get the medical history, right, then we start to look at what is going on. We look at the patient. Is their skin color okay? Is it pallor, right? Is it full of rashes? Do they have rosacea? Do they have eczema, right? Do they look malnourished, right? They're eating, but they look very malnourished. They look like they haven't eaten in a long time. It creates problems. Those are signs of malabsorption. Does the patient have neurodegeneration? Are they very forgetful? Did they lose their sense of smell or taste, right? Is their balance off? We look at all these neurodegenerative signs. And then do they have history of autoimmunity? Do they have rheumatoid arthritis or hypothyroid? These are all things you have to look at in a patient. Does their thyroid look puffy or a little bit swollen? You have to ask those questions, but you also have to clinically observe what is going on with that patient. Is the patient's handwriting very small, or is it very large, or is it very shaky? All those things matter in terms of looking at a patient from beginning to end. And the physical exam, right? We have to do the physical exam. Oftentimes, doctors are forgetting the art of a physical exam. Listening to their lungs, listening to the bowel sounds, right? Palpating the thyroid, doing a neurological exam. You have to be able to do that and put it all together to find a solution for those complex patients who have GI issues or GI-related symptoms, which they are unaware of that is related to GI. Or sometimes it's just neurodegeneration, right? Or degenerative processes that affect the enteric nervous system. So you got to look at the physical exam findings. Then we like to run labs, right? I often find patients come in and they get labs from their primary. And oftentimes it's just, cholesterol and maybe a CBC, right? It's not comprehensive enough sometimes. So our routine blood work, we like to look at a whole panel of things and look at if the patient has inflammation, do they have thyroid issues? Is their homocysteine levels up, right? Do they have vitamin D levels that are appropriate? So when we do our routine lab work, it can help us determine what direction to go. Sometimes the routine blood work will pick up things that was missed on maybe smaller panels. So routine blood work is very important. When we look at GI, there's a lot of invasive testing involved also, right? Endoscopy, colonoscopy, biopsies. You can do all these types of invasive tests to figure out what's going on. And you need that sometimes to rule out pathology. Do we have a physical issue, right? The other form of testing that we use is what we call functional medicine specialty labs. So this is looking at food sensitivities. We use a company called Cyrex Labs, and they look at different types of foods, right? But they look at it in terms of either cooked and uncooked foods, because the protein of that food will change when it's cooked. So looking at food sensitivity is very important. Looking at autoimmunity is also very important. Sometimes doing a stool pathology test would be very important. In our office, we use something called a GI map, and we look at the gut microbiome, but we also look at all the different types of infections that can be possible in the GI. And the way this lab does it is through DNA testing, right? Not just look at it in a microscope and say, do we have a worm? They look at DNA fragments and looking at DNA material of bad bacteria or pathogens, right? So it's important to do that if we have an unresolved GI issue. So oftentimes patients come in and they've done invasive testing because they've had long-standing issues for their GI. So they've been to doctor, they've been to gastroenterologist, and then go to a dermatologist because they have skin issues, and then they go to a neurologist because their cognitive abilities are declining. So they've been to many doctors prior to coming into our office. And our job is to kind of put all that together, add in some additional testing, look at a comprehensive case review, and then determining what is the next course for this patient. What is the next step? And usually the foundational piece needs to be in place, which is diet, nutrition, and lifestyle, right? Foundational stuff. Then we can build on that and say, what else can we do? So in our office, we take a really comprehensive approach to GI dysfunction. Today, we're going to do part 3 of gastrointestinal disorders, and we're going to go over the different mechanisms and how we think about patients when they come in and have GI issues. Okay? So on the board behind me, we're going to look at the red portion first, okay? The red lettering. When we have a patient that comes into our office, we evaluate them from north to south, basically from mouth to rectum, okay? So north to south type of clinical thinking is necessary in order to determine what type of patient this person is, what type of condition this patient is coming in with, and where do we have to go first, all right? So when we look at this continuum, we have north to south in terms of symptomatology, right? When a patient comes in, do we say, do they have proper smell? Can they smell things, or they have lost a sense of smell and taste over time, right? Do they have proper saliva production? When they go, and look at their mouth, the tongue should be shiny and red. Do they have proper saliva production? Do they have fungal overgrowth or candida in the mouth? Can the patient swallow, right? When we go open, say, and we should see that palate move. Some patients, when we repeat the movement and go, the palate no longer moves, right? So we have to make sure they can swallow. Do they have enough HCl production, right? Hydrochloric acid production in the stomach? Do they have proper pancreatic enzyme release? Do they have a gallbladder, right? Did they have their gallbladder removed? Or is their gallbladder sluggish as a result of maybe autoimmune disease like Hashimoto's thyroiditis? Then we have duodenal microvilli, where we can absorb foods properly. Intestinal permeability, that can be a lot of different causes. ICV is ileocecal valve. It's a valve in the right lower quadrant that prevents bacteria from the large intestine to migrate into the small intestine. And malfunction of the ileocecal valve can create things like SIBO, or small intestinal bacterial overgrowth. Oral tolerance. Does this patient come in, they can only eat 10 foods, otherwise they get very bloated, they feel sick, they feel nauseous, right? Do they have proper oral tolerance? Microbiome, right? Do we have gut diversity? Do we eat a wide variety of vegetables and fruits to have the right gut microbiome fuel as well as the right microbiome? Colon reabsorption of water and excretion of fecal matter, right? We look at the patient from north to south and then say, what is the underlying mechanism? So if we look on the bottom over here, we look at patients in terms of, based on those symptoms, can they have a neurological problem? Do they have a GI infection? Do they have a metabolic problem like insulin resistance or diabetes, right? Immune dysregulation or autoimmunity. So when we look at this continuum and we intersect it with the symptoms and you know what the patient is experiencing, then we can kind of come to a conclusion as to where the problem might be. It might be autoimmune, it might be metabolic, it might be even neurological and early neurodegeneration like Parkinson's or Alzheimer's or dementia, right? So just to recap, north to south, when you have loss of smell, it can be a neurological problem. It says neuro, right? Saliva production could be neurodegenerative, or sometimes medication can do that. Dry mouth and so forth. Chewing could be a problem with muscles of mastication, right? It could be a neurological issue, or it could be a TMJ, a physical problem, right? Swallowing, that can be neurology. It could be something called the vagus nerve. Can we have the proper swallowing mechanism? HCl production could be metabolic, it could be due to antacids, poor food choices, as well as infection and neurology. Pancreatic enzyme release can be neurological also, or can you have a physical issue there? Gallbladder release of bile could be metabolic or autoimmune. Duodenum or microvilli, celiac disease, food issues, it can kind of decimate the gut microvilli. Intestinal permeability can be antibiotics or SAD or standard American diet issues. IC valve is neuro, or it could be SIBO or small intestinal bacterial overgrowth. Oral tolerance could be SIBO, neuro, gut microbiome could be lack of diversity in the gut due to poor food choices, and then dietary intake. So we look at a patient in terms of their symptomatology. We go through kind of this whole checklist, and then we try to match it with what the underlying mechanism might be for a patient. Where is the underlying problem, right? Is it neurological, infection, metabolic, immune, or autoimmune? So if you have an infection and you just treat it like it has just a digestive enzyme issue, then is that patient going to feel better? Maybe a little bit, but you have to eradicate the infection for that patient to really feel better, right? So I'm going to flip this board. And I'm going to give you two cases, okay? So a patient comes in and they tell me, or during my examination, I realize they can't smell very well, right? And then when I check the neurological portion or the vagal function, they have poor vagal function and they have difficulty swallowing, right? This is the person who eats and takes forever to eat, right? They're a slow eater. They can't swallow, they just keep chewing, right? HCl release, you have pancreatic enzyme release, ileocecal valve, and excretion of fecal matter. Let's say they're constipated all the time. No matter what they do, they're always taking a laxative, right? They need a special tea. They're always trying something in order to get the bowels moving. All these signs right in here can be an early sign of neurodegeneration. So this patient who has all these problems is likely going to be a neurological patient, not just a GI patient, because you have to fix the underlying mechanisms. So all neurodegenerative patients are progressive, right? No matter what you do to halt it, you might be able to help them in a certain way, but if they get too far advanced in their neurodegeneration, our job is just to stop it from progressing, because neurodegeneration will progress over time, okay? So you have patient number one, we have all these symptoms, and it's most likely a neurological patient. Now when we look over here, we have a patient who has gallbladder release, they have a problem with gallbladder releasing their bile, their duodenal, the microvilli has malabsorption issues, and gut microbiome development is no good, right? So let's say you have somebody who has insulin resistance and diabetes, right? They're eating very poorly and so forth. They're going to have poor gut microbiome, and they're going to atrophy their microvilli. And then if you have, a patient who goes, you know what, I can't even eat fish oil. If I have fish oil, I burp it all up. And then when you check their blood work and their vitamin D, despite them taking, let's say, 5,000 units of vitamin D, their vitamin D will still be low. So we look at these patients and we go, what kind of patient is this? When we look at a patient like this through a clinical lens, we say this patient is a metabolic patient. Okay? So we handle patients very differently from a neuro patient to a metabolic patient. first point of attack might be different for these two patients, right? So we have to say, on top of this, do they have autoimmune disease? Do they have other underlying mechanisms? It's important to understand that north to south mechanism, and then trying to pinpoint, what is it? Is it an infection? Is it autoimmunity? Is it dysregulation of the immune system? Is it neurological or metabolic? We have to figure those things out in order to properly attack a problem, right? And I'm going to be honest with you. Every patient that walks in our door, we can't guarantee that we can help them. Some of these patients are so far advanced in their neurodegeneration, no matter what we do, we probably won't change things. We can help their quality of life and do some things. And then you have some patients who come in and they're eating a poor diet and they have all these things going on and they have all these symptoms, yet if we do a few things for them, it can completely change their lives. So it really depends on the individual, what is happening with them, how long these symptoms have been ongoing, and what is the motivation of that patient to get better. Oftentimes when a patient comes in, I go, hey, listen, based on what you're telling me and some lab testing that we did, it looks like you have issues with gluten, which is your breads and pastas. You have to stop eating gluten. They just go, I can't do that, doc. Then my answer is, I can't help you, right? So the patient's motivation and drive is also necessary in order for them to recover from any gastrointestinal issues, okay? So my name is Dr. Jin Sung, where clinical excellence meets excellent results. And we'll see you guys next week on the healthy side. And next week, we're going to start a series on thyroid issues.